about their menstrual irregularities or about their PID or any infections or discharge or something. They feel that if the patient is accompanied by their husband or like mother-in-law or mother, sometimes we feel that if the patient doesn't tell you the proper history clearly, then try to maintain a private space between the patient and you. Then only they will sometimes tell, because in an infertility patient, when the menstrual irregularities comes, so usually patient will come, yeah, only after marriage I am having this type of menstrual irregularities. So if we ask the patient regarding that in private area, private space, or we give some privacy to the patient, irregularities, they do treatment, and again now the irregularity key. So in some cases we had to build a good rapport with the patient. Then only they will tell you more clearly about the gynecological related issues. And we had to be a good in a listening mode, or then only we can get all the relevant points regarding the condition. So just like that, in initial phase we had to collect the personal data, the age is important when this menorrhea type of complaints are more seen in young women. Then fibroid, irregular menstrual cycle, adenomyosis, such type of cases are more common in the elder age ladies. And also marital status is important, because we can do only per vaginal examination only in a married lady would know. So marital status, occupation, regarding the stress is there or not, that we had to all assess. And what is the presenting complaint? So if she is having any menstrual irregularities there, so when did the cycles become irregular? So we had to start from the LMB, or start from the menarche itself. So after menarche, when the cycles become regular, when it become irregular, how much months does a cycle become irregular, whether she taken any treatment for that, all that thing we had to ask. And if it is she's having any dysmenorrhea, so when the dysmenorrhea started, or whether it started 2 to 3 days prior to menstruation, or whether the pain is there throughout the menstrual cycle, or if there is any vaginal discharge, is there any relation with the menstrual cycle. In some cases we can see just prior to the menstruation, this vaginal discharge condition become increased. So we can ask about the complaints, and whether that it is related with the menstrual cycle, or how severe is the condition, that we can ask in history taking. And also regarding the maturation and all, regarding their bladder, most of the ladies may have a habit of recurrent urinary tract infection, especially in the cases like PID, or even in cases like vaginal discharges and all. Is there an association with this type of recurrent UTI? That also we had to keep in mind. And also ask whether the lady is having, especially after the delivery, or in an elderly lady, if she is having any stress incontinence, like whether in coughing or sneezing, whether the bout of urine is passed, like that we had to ask. And also about the bowel habits, about the constipation is there, or the blotting or flatulence is there, or ask for any abanovaigunia, we can ask for that. Then regarding the menstrual history, we had to ask from the age of menarche itself, like whether the cycles appear normal, whether the menarche occurred normally, or whether it is induced or not. That also we had to ask. And also if we are looking for the regularity, even if the patient tell you that my cycles are regular, every month I got periods, like that, then also you ask about the menstrual period, especially the last menstrual period. Most of the patients may have app and all, so they will easily note the menstrual date and all. So ask for the last 2 menstrual period. Then we will know whether the cycle is regular or not, and ask for the length of the bleeding, that is whether how many days the bleeding is, like it's about 5 days or 4 days or 7 days, and whether there is a proper bleeding is there any clot is there, or is there any color difference or any smell difference. That all thing we had to ask clearly. Or if there is any pain associated during the menstruation cycle, or if there is clot, or even membrane type of such type of membranes are seen or not, like all these things we can ask. or sometimes the patient may have like spotting in between, like the spotting starts 2 or 3 days prior to menstruation, and even after menstruation 5 or 6 days there will be spotting. So that also we can ask. And in some patients we can see like post-coital, after a sexual contact they have like spotting or bleeding, or sometimes the patient may like in after doing a heavy exercise or traveling and all they have some spotting and bleeding. Such type of presentation is there or not, we can ask for. And also if the patient complains of there is pain in the or dysmenorrhea, or if a secondary type of pain is there, then we had to ask for the location. Where is the pain? Is it in the lower abdomen, or is it in the right or left iliac fossa? We had to clearly ask where the pain is. And also, is there any pain, like the radiating type of pain is there, or is the pain related to menstrual cycle? Or even some ladies have like chronic pelvic pain. Throughout the cycles, they are having pain and like vague aching type of pain. Sometimes in endometriosis or sometimes in PID, such type of presentation will be there. Especially during the periods, they are having like severe pain. After that, the pain will be mild, but throughout the cycle, they are having aching type of pain. So we had to clearly collect all the details regarding that. And then we had to ask about the obstetrical history, whether the lady had delivered number of children, whether abortion is there. If abortion, of course, that whether there's a D&C, or like that if some patients who are having like 2 or 3 D&C is there in their like in the perimenopausal period, there's an increased risk of prolapses there. So such things we had to keep in mind. And also if the patient is having any abnormal vaginal discharges there, so we had to ask the whether it is having any relation to menstrual cycle, or what is the color, like it is like a mucus type of discharge is there, or like a milky type of discharge, or like a curd type of discharge. So depending upon the color of discharge, or if it is like an yellowish greenish type of discharge, so yellowish green, that means there is an infection, no? If it is like a curdy white, then maybe candida type of infection. So with the color, consistency, or if associated symptoms like if the odor is there or itching is there, then we can come to a conclusion or to a diagnosis. It will help us. Or also we can do an examination in such type of patients if they complains about this vaginal discharge. Sometimes we can see if the patient is there having mild discharges there. But when we are doing a speculum examination, we can see that there is severe infection in the cervix or in the upper vaginal tract. So even a patient complains of discharge, try to do a speculum examination if possible. And also ask patient about a family history of diabetes, hypertension. So diabetes, if in a patient of PCOS with a family history of diabetes, then we can suspect the patient is like a pre-diabetic or insulin resistant state. So along with the PCOS medicine, we had to give medicine to this that condition also, like in a pre-diabetic or insulin resistance. Then only our treatment will get a very good result. And also if the lady is sexually active, so we had to ask about the whether there is any dyspareunia is there. Dyspareunia means pain during sexual contact. And also we had to ask whether it is a superficial or deep dyspareunia. Superficial means around the opening of vagina if there is pain, or something deep means inside on the upper vaginal area they are having pain. So deep dyspareunia usually occurs in the pelvic inflammatory disease, especially in a severe type of vaginal infection, vaginal cervical infection. They are having this deep dyspareunia, or even cases with endometriosis, they are having this dyspareunia. And sometimes if some patients tell that even after a sexual contact, their vaginal infection just increases. That is also type of clinical presentation for chlamydial infection or bacterial vaginas also. Such type of presentation we will get. So that also we had to ask about the past treatment history regarding even regarding the dysmenorrhea, or some patients may have this laparoscopic correction for they have whether they have like an endometriosis, or if the cyst is there, chocolate cyst, or even the clear cyst is there, any cystectomy done, or any treatment for PCOS, or any adhesional lysis treatment. So we had to ask for any past treatment history regarding this. And also thyroid related issues are commonly seen in reproductive age ladies. So thyroid related, if they are taking any thyroid medicines, or also that also we had to keep in mind if they're having any. And also if the lady is planning to conceive, then also we had to, it's mandatory to check the thyroid level. And also when we are talking to the patient for like past 10 to 15 minutes, when we are taking the proper history, we will get a very good idea about the psychological status of the patient. So the psychological status of the patient is also very important, because in some cases, especially in dysmenorrhea and all, pain is a subjective symptom, no? So if the patient is having a good sattva bala, so then the patient may sometimes present that as even only a mild presentation or mild symptom only. So if a sattva is like avara sattva, then even with a mild pain, they will present it as a very big symptom. So the psychological status of the patient should be also assessed when we are taking the history. Along with the history, we had to also do a physical examination, especially if a lady complains of abdominal pain, or just do a physical examination, just do an abdominal palpation. Sometimes we can, if there is some like pelvic any mass or something like that, we can easily feel the pelvic mass. Or even if the lady is not in a menstruating phase, we can do a per speculum or a bimanual examination to get into a proper diagnosis. But or if speculum examination is not done, then also try to do just an abdominal palpation to see whether there is any pain or tenderness in both iliac fossa, that is lower abdomen is there, the area below the umbilicus is the lower abdominal area, and just to side of it is the right and left iliac fossa. If there is any pain or tenderness in the iliac fossa, we can suspect there may be any like any PID or any cyst or like endometrial adhesion will be there. Like that, we can just differentiate. So for getting a better conclusion, we can use the help of the investigations. Like commonly, we can do an ultrasonography. You can do an ultrasound transvaginal ultrasonography if the lady is married, and transvaginal ultrasonography will get a very good idea about the ovarian condition. So if we want to we want to get an idea about the ovarian condition, it is better to do a transvaginal sonography. Otherwise, we can opt for a transabdominal sonography. And also, if the patient is not able to do a USG, then we can also do a bimanual examination to see whether the uterus is normal, or if it is a lean patient, we can easily palpate the ovary, the fallopian tube, and also if it is, we can easily palpate if the patient is very lean. So if you're doing it regularly, then you can master it. Next is the female, as we all know, the female reproductive system. So some of the most common conditions that are related to the female reproductive system is like if the related to the endometrial, this is endometrial layer. So if the endometrial thickness is more than 8 millimeter, especially the normal thickness is 8 millimeter, if it is more than 10 or 12, then this endometrial hyperplasia. Or if some fibroid which encroaches into the cavity. So the submucosal fibroid which also increases the bleeding, or sometimes the fibroid is seen in the muscular layer, intramuscular layer. Then also adenomyosis, which are the common conditions related to uterus. And related to ovary, we will get common conditions like PCOS or chocolate cyst or even simple cyst in the ovary. And or sometimes we'll get cases like there is infections in the fallopian tube related to the pelvic inflammatory condition, or even the hydrosalpinx, that fluid filled in the tube, or regarding the endometriosis. Along with endometriosis, the tube may be occluded, and the endometrial implants may be seen in the tube. And sometimes in the cervix, we can see cervicitis, the infection of the cervix will be seen, or there may be infections in the vagina. It can be a candidal bacterial vaginosis type of infections in the vagina. These are the common cases that we get in our OPD, like dysmenorrhea, PCOD, endometriosis, sometimes heavy bleeding. So heavy bleeding, it can be due to like endometrial hyperplasia, or even due to fibroid, or discharges we will get, fibroid we will get. These are some of the common cases that we generally get in our OPD. So we will start from dysmenorrhea. Dysmenorrhea, the term itself is like painful menstruation, just like we can say it like kashtartha. It's a symptom only, no? So sometimes there may be an underlying pathology. Sometimes it can be simply a functional defect only. So we can classify dysmenorrhea under kashtartham, vajayunivya, udavartini, etc. So it is the most common gynecological complaint that we get in our OPD. As we had already said, it is like a pain is like a subjective symptom. So sometimes a patient may have like may present it in a more severe form. So usually younger age women, especially like 15 to 24 age, when they have more chance of primary dysmenorrhea. But we also had to keep in mind even in younger age lady, we can get cases like endometriosis or chocolates like that cases also even in younger age we can get, or these ladies may be a potent like they may have or they are in a higher risk category to develop such secondary type of dysmenorrhea. So that also we had to keep in mind. Even sometimes we if we are doing an if we are doing an ultrasonography, if we are doing a clinical evaluation, if we don't find any secondary causes also, if the patient is having severe dysmenorrhea, so we had also we are also responsible to prevent the secondary pathologies. So dysmenorrhea, we know that the monthly pain, it affects the normal their day-to-day activities, it affects their productivity, or it increases the work abstinence. So most of the patients are having like they are like fed up with the pain and they come to. So dysmenorrhea may be a primary and secondary. Primary means due to like the functional defect only, like the intrinsic factors. So secondary dysmenorrhea means it can be due to so many factors, like it can be due to endometriosis, it can be due to any pelvic inflammatory disease, fibroid, or any secondary cause like irritable bowel syndrome, any recurrent UTI or mullerian duct anomaly, or intrauterine contraceptive devices. So there are so many causes which may contribute to secondary dysmenorrhea. So when a patient complains about the pain. So first you had to analyze the characteristics of pain. Like usually in a primary dysmenorrhea, there will be a vague aching type of pain. And it usually, the pain will start like 2 to 3 hours prior to menstruation. And even the pain may last through one day. But if the pain lasts for more than like 2 or 3 days or throughout the menstruation, or sometimes the pain start like 2 to 3 days prior to menstruation, or even pain lasts throughout the cycle, or even after that the pain gradually subsides. So such things we had to ask the patient, and also the associated symptoms. If the patient is having like vomiting or something, some like back pain, or like the PMS related symptoms is there, or if they're having any like bilateral tenderness is there, dyspareunia is there, or associated symptoms also we had to ask, which will help us to get into a diagnosis. So usually the pain will be especially in the hypogastric area, like a vague type of pain, usually in the primary dysmenorrhea, and sometimes the pain may be in the lower abdomen, and especially in all, and also in the back. Hello,
Madam,
doctor, am I audible?
there is a small disturbance in your voice, ma'am. Hello, madam.
Okay, okay. Is it clear now?
It is clear now. Sometimes it
Is
is
it
coming.
clear, doctor?
Small disturbance coming.
Is it clear, doctor? Shall I continue?
Yes, ma'am. You can continue.
Shall I continue, doctor?
Yes, ma'am. You can continue.
Okay, the pain is there in the lower abdomen, and sometimes the patient is having like low back pain will be there, and sometimes the patient may complain if there is pain in the right or left iliac fossa. So these are the light of left iliac fossa. If the iliac fossa pain or tenderness is there, you had to suspect some underlying cause. Either it can be due to an ovarian pathology or like a tubal cause will be there. And if it is the right side, we had to always exclude the appendicitis also we had to exclude. So the area of the pain like the intensity of the pain, all we had to ask for to exclude our diagnosis. So usually, like in the primary dysmenorrhea and the spasmodic dysmenorrhea, the pain will be like a colic pain. And sometimes we can see, especially in the students or teenagers, we can see the psychological dysmenorrhea, especially related to exam time and all, and or even if some work related like pain and all. Especially the patient tell you that I'm having this minor type of pain for past 2 3 months. Then we had also try exclude the psychological and stress related dysmenorrhea also. We had or physio like mentally unstable, or due to any like family related issue will be there, or any work related stress will be there, which all contributed to the psychological or stress related dysmenorrhea, which reduces the pain tolerance limits there. That's why they may present it as like a severe symptom. And usually the patient will try like hot water bag, and sometimes they will try with the pressure related like therapy. And even some patients like this ginger, which is having a very wonderful effect. It acts like a non-steroidal anti-inflammatory drug, like the cyclopam. So it reduces, studies are there which reduces the prostaglandin secretion, thereby reducing the pain and all. So in modern, they usually give the cyclopam related or the prostaglandin synthetase inhibitors they usually give. And in Ayurvedic point of view, we can consider it under the Shulam. As we all know, there is a role of Vadam, and we can see that the Vada Prakriti patients or Vada Pitta Prakriti patients, we can see they're having more of this pain related issues, especially this dysmenorrhea and all. They are having more seen in Vada Prakriti or Vada Pitta Prakriti subjects. If there is a Kaba Anubandham, the pain tolerance, right, the pain level will be much less. And we can see this dysmenorrhea as a clinical sign in various yoni habits like Vadagi, Sanivadagi, Paripluda, Udavartni, Andarmugi. So always try to exclude any secondary cause. So some of the common medicines which we can give in this primary dysmenorrhea like Gandharvastadi Kashayam, Hingvajadi, Vaishwanaram, Saptasaram with Hingvajadi, which we can give like throughout the cycle, or even in an emergency, if the patient is having severe pain and who come to you, then you can give immediately like a cyclopam effect. You can give Amritaristam Punarnavasam Vettumaran tablet as an emergency pain relieving medicine. And also you can give like Abhayarishtam Dhanundram tablet combination, or Sugumaram Kashayam with Nisrasneham, or Dashamula Shira Kashayam. If we are giving Dashamula Shira Kashayam, especially the patient is a Vada Prakriti, for 3 consecutive months, the pain will be reduced dramatically. Dhanimadikritam we can give, Dhanundram Kashayam, Dhanundram Guliga, Avagaham we can give, and Ashogashtam we can give. So these are the common medicines we can. And also we can give like Matra Vasti. We can advise Matra Vasti, especially 10 days prior to the next cycle. Matra Vasti we can give with Mahanayarana Thailam or Dhanundran Thailam. Even 60 ml has a very good effect. Matra was the gives which we can give like 10 days prior to the next cycle. It has a very good effect. And also we can advise the patient some yogas like Bhujangasanam, Matsyasanam, Vajrasanam, Dhanurasanam, Surya Namaskaram, Shavasana. Advise the patient to practice this like 10 days prior to menstruation, which reduce the pelvic congestion, and the patient may have much better results. Next is the polycystic ovarian disease. Polycystic ovarian disease is also known as teen Leventhal syndrome. Sometimes, when the patient is doing an ultrasonographically, they may come to you with a teen Leventhal syndrome. Some labs will send the report like teen Leventhal syndrome only. So PCOS is also one of the most common affected case. Almost 160 million women are suffering worldwide. Even it is a lifespan disorder. Even we feel that after menopause there is no issue regarding PCOS, but even after menopause, the consequences of the PCOS, that there is, will be an increased risk of developing diabetes mellitus, hypertension, even cardiovascular disorders, and even endometrial CA is also common in PCOS subjects. So if we are like even after menopause also, if we are like following the proper diet and lifestyle, we can advise the patient to follow proper diet and lifestyle in order after the menopause. So in the PCOS, we can see there is there is insulin resistance will be there, hyperinsulinemia. It's a metabolic disorder, but it is having a strong regarding the PCOS. Usually they will come to you regarding the menstrual irregularities. That is the most common presentation that we will get there. It will come to you like 2 months, 3 months. They're having an absence of menstruation. That may be the common presentation, or sometimes come to you with regarding infertility issue, or sometimes come to reduce weight, or even the cosmetic issue, especially hirsutism or pigmentation over the neck and all, they come to you. So these are the common clinical presentation we will get. So some patients will come to you with an ultrasonographically says that they are having this bilateral polycystic pattern is mentioned in the report. So I'm having PCOS, give some medicine like that, they'll come. But if we when a patient come to you with this type of report, so out of the three symptoms, if the patient is having only two symptoms, then only we can consider it under PCOS. So she should have like irregular cycles, clinical hyperandrogenism, and even ulcerative colitis. So if the PCOS, the ovarian volume should be more than 10 cc. Okay, so usually 6 to 9 cc of the ovarian volume. So the normal ovarian volume is 6 to 9 cc. If it is more than 10 cc, you can also see patients within 20 or 22 cc patients volume of the ovary. You can see. In some cases, the lab may not give the volume in cc. They will see give only a measurement. So if the measurement is given like this, 3 into 2 into 2.2 centimeter only, then you can find ovarian volume by multiply it with zero point 0.5, then you will get the ovarian volume. So polycystic pattern or polyfollicular pattern means periphery. We all know periphery arranged follicles. The follicular size should be less than 9 millimeter. So it is the periphery arranged follicles. So these follicles are like they are healthy follicles, but without the proper FSH hormone, follicular stimulating hormone, these follicles are like in this like the semi developed state. So PCOS is a even it's a lifestyle disorder we are considering, but it has a strong family history. Sometimes you can see very obese ladies, like they are about 90 kilos and all, without any PCOS, without any menstrual irregularities, you can see. So there is a strong family history. There is a strong family history regarding the insulin metabolism. Okay, the glucose metabolism. So insulin resistance is a major cause. So if the lady is having any family history of diabetes and all, if her lifestyle is like sedentary lifestyle and she take more junk foods and all, obesity is like that, she's obese, then there's a high risk of developing PCOS. So usually we can see most 30 to 70% of PCOS are obese. That we are having high BMI. So initially this fat tissue are having a capacity to convert the estrogen. There is a peripheral conversion of estrogen. So this estrogen will send a negative feedback. So FSH will not be produced properly. So the balance between FSH and LH is altered. So there will not be ovulation, will not be occur. And all the cause, all the pathology start from here, from the pancreas. So our treatment also aim at this area. So when the patient is taking more glucose or more carbohydrate or more sugar diet, so then there will be a more glucose in the body. So the insulin, there will be more insulin will be produced. But this insulin, there is an insulin resistance is developing. So this insulin resistance is developing. So the pancreas is forced to produce more insulin. So there is a hyperinsulinemic environment. So this hyperinsulinemic environment will always favor there is an increased production of testosterone and low sex hormone binding globulin will be produced. So this low sex hormone binding globulin will be there now. So there will be more free androgen or more free testosterone will be there. So these testosterone, this hyperandrogenic environment will not favor ovulation. So ovulation will be hampered, and this FSH-LH ratio will be also hampered by the estrogen hormone. So the negative feedback will be there. So our treatment should be aimed at these two levels. We usually give medicines to correct the ovarian volume, to correct the ovarian function, and all. But we had also, to get a better result, we had to start medicine from these two levels. So first we had to advise the patient to cut excess sugar, excess carb and all. Though then the and also advise the patient to do a very good exercise, especially a good cardio and like 30 to 40 minutes good cardio. So exercise will reduce the insulin resistance. So the main pathology is like it is solved. Then we had to give medicine to support the proper liver function. Then proper sex hormone binding globulin will be production will be corrected. So we had to give medicines to correct the liver function. We can give Arogivardhani, we can give Padoladi and all. And for correcting insulin resistance, we had to advise the patient to treatments to correct insulin resistance. Like in a pre-diabetic stage, we can give like the Nishagata Kati Kashayam and all, along with the medicines to correct the ovarian function. So then we'll get the better result in managing PCOS. So usually we will get so many type of PCOS patient. Like sometimes the patient may have all the three symptoms. They are having like hyperandrogenism, like they are having excess hair growth on their face, their cycles is irregular. When you're doing ultrasonographically, the ovarian volume is high. So all the three symptoms are there. So they are classified into phenotype A or frank PCOS. Sometimes when allopathy doctors say, like when the patient comes with you the prescription, you can see frank PCOS. They will written like that. So if all the three symptoms, the hyperandrogenism and ovulatory dysfunction is there, then it is phenotype B. Like that, we can see so many variety of PCOS patients, sometimes lean, sometimes obese, sometimes with all the three presentations. So depending upon that, the Rotterdam's criteria is mentioned this type of phenotypes in PCOS. So hyperandrogenism means there is excess androgen production in the body. As a result of this excess androgen production, certain clinical pictures we can easily get. One is this hirsutism. Hirsutism, we all know there is excess hair growth in specific areas. So if in specific areas only, like if there is hair or if like male pattern of hair all over the body, then it can't be considered under hirsutism. So hirsutism means a specific like the conversion of terminal hair to vellus hair in these specific 9 areas, then only we can consider it under hirsutism. So usually this pilosebaceous unit, that is this hair follicle, no, so they are very much sensitive to the androgen level. So when the excess androgen is there, so the normal hair gets converted, it get more pigmented, it get more thick and all. It is completely converted into this new like thickened hair. Next is insulin resistance. Insulin resistance we had discussed, no. So the body, even the cells are not taking up the proper insulin. So they are not like accepting it as insulin, like that we can say. So if insulin is not like if it is not utilized by the cells, so then there will be more glucose will be there. So it will be more deposited in the liver and all, and also in the it will be converted into fat cells. So obesity may result in that. So even the PCOS, if we are advised the patient to reduce weight, they find it very difficult to lose weight. Along with medicines, we advise the patient to reduce weight. They find it very difficult to lose weight because the mechanism is already like altered. So it is somewhat a difficult task for them to lose weight. Along with medicines, we advise proper exercise and all, it will be easier for them to reduce. And also in every PCOS patient, try to do a fasting blood sugar level. So if and also do an HbA1c level also to see whether the how the insulin resistance is there in the patient. So acanthosis nigricans also, sometimes we can see the patient, we can see the pigmentation of the on their neck and all. We can see that the patient is having this acanthosis nigricans, no, the pigmentation over the neck area, sometimes on the axillary region, sometimes on the like the folding area of the arm or in the popliteal fossa and all. Very much pigmentation, dark velvety type of skin. This is a visible manifestation of this insulin resistance. So either the patient may be in a pre-diabetic stage or the patient may be in diabetic stage. So along with the like prameha aushadhi, along with the PCOS management, we had to give prameha aushadhi to control this condition. So usually the patient may come to you with menstrual irregularity. Sometimes the patient may have like amenorrhea for like 2 to 3 months, or sometimes they may have or some patient may have like medicines to induce the menstrual bleeding and all. Or if menstruation occurs due to less unopposed estrogen, because there is no ovulation, no, so the progesterone is not there. So because of this unopposed estrogen is there, so the endometrial thickness becomes so thick, so the patient is having like severe bleeding. When menstruation occurs, there will be severe bleeding will be there. And also we can see some patients even like 2 to 3 months of amenorrhea, if their menstruation occurs, there will be spotting only. Such type of cases also we can see. So there is some difference in each and every patient. So we had to understand the condition of that particular patient, then we can give the medicine. So in this PCOS patient, because of, as we had discussed now, because of the altered FSH and LH value, proper ovulation is not taking place. So a lack of ovulation or even infertility issues we can see. So in some lean PCOS patients, we can see PCOS with in a lean patient. So in that case, we can say that it's purely a genetic factor, maybe reason. So in such cases also, we can see compared to an obese patient, there will be less insulin resistance. There will be less this acanthosis nigricans or hirsutism and all. The obese PCOS, they are having more this menstrual irregularities, hyperandrogenism, and also they are having more acanthosis issues. And so compared to lean PCOS, the clinical presentation is more even in obese PCOS. So investigation we had, as we all know, the body mass index, HbA1c and AMH. AMH level will be much higher in PCOS, especially it will be more than 6 or 8, something like that. We can see normally it is like 2 to 4 is normal, but in patients with PCOS, the AMH level will be much higher. So along with our medication, we had to properly correct the diet and lifestyle. Then only the insulin resistance and the liver function will be corrected. Then only our medicines will act properly. Especially when the insulin resistance is reduced only, then only the liver function will correct. Then only our medicines will act at the level of the ovary. So if the patient come to you with like the patient is having like absence of menstruation, so our first aim is to induce menstruation. So if the endometrial thickness is correct, so endometrial thickness should be minimum 8 millimeter, no. So if the endometrial thickness is correct, then we give medicines to induce menstruation, then menstruation will occur. But if the thickness is less, if the thickness is like 4 or 5 millimeter, then we don't give this treatment to induce menstruation. First, to give medicine to correct the endometrial thickness, then give medicines to induce menstruation. So, to induce a cycle, we can give some Agneya, like Agneya also, which are having an anulomana property. Like we can, if it is a mild PCOS, and then we can give Saptasaram Kashayam with Hingvajadi or like that, we can give. Or we can, if it is like a little bit more, we can give Kanashatahwadi, then we can give Chitragrindhyadi. So if the patient is like more pitta prakriti, please don't give chitra granthiyadi and all. And also we can give tilak kashayam. Tilak padam we can advise the patient to prepare at home also. And also, if not possible, we can advise the patient to buy some black sesame seed with this jaggery and a little bit of hingu, and advise a patient to grind it in a mixie and advise the patient to take 1 or 2. Then also will induce menstruation. If the menstruation has started, just tell the patient to stop this medicine in order to prevent excess bleeding. Sometimes there is a high risk of developing heavy menstrual bleeding. So when the menstrual bleeding has started, advise the patient to stop taking this medicine. Sometimes the patient may continue this medicine throughout the menstrual cycle. So that also we had to advise the patient. We can give like Panchakolasam, Kumariasam, Abhayarishtam Vidhanataram Kulika, Gandharvastadi Kashayam, all or even Kulatadi Kashayam, all are having a property to induce menstruation. Or if the endometrial thickness is less, then we can give like Dadimadi, Shadavadi Kritam, Sukumara Kritam, etc. We can give to for correcting the proper endometrial thickness. Then it will be easier for to develop or to get menstruation. Or even a good Udvartana will stimulate, yeah, this menstruation. And if we fail with all this medicine, we can admit the patient for an Udvartana for 5 to 7 days. Then definitely menstruation will occur. Then, if the patient is having, if the patient has started menstruation and the patient is having heavy bleeding, so in this phase only we are doing a Pitta Shamana line of treatment. In this other time, we will do only Vada or Kapha Shamana line of treatment. So in this phase only we are doing a Pitta Shamana type of treatment. So in such cases, we can give like Pitta Kashayam, Trayandyadi, usually Musali Gadradi Kashayam, Pushyanagam tablet, or Shadavari Kritam, Pravala Basmam, Stipulon, Point capsule, or we can give. Like for a proper clotting, there is calcium and this iron is needed, no? So along with the medicine, also check the HB level and all to see to especially if the HB level is much less, then the medicines won't act. So in between the cycle, we had to correct the HB, we had to correct the cause and all. So the commonly used medicine to reduce the ovarian volume, to correct the ovarian function, we can give this Kanashadavadi Kashayam, Varanadi Kashayam, Sukumaram Kashayam, we can give Saptasaram Kashayam, or Saptasaran Kashayam with Sukumaran Krudam, we can give a Pipalya Dhanvasana Thailam, we can give Hulatadi Kashayam, Tilakwadam, Chidvilvadi, Kindarvastadi, Shaddaranam, Ashokarishtam, Kumari Asam, Pulinkoyambu. Kanjanara Kukulu is having very good effect in reducing the Grandhi level, or like hyponet, some patent medicines like hyponet, all are having a very good action in correcting the ovarian function and also help to induce the ovulation and all. So, along with the medicine, diet and lifestyle is also must keep that in mind and advise the patient also. So, even after like menopause also, or even after the menopause or even the even after like if the patient is if the PCOS is not corrected, it may complications like infertility, or even it may cause the recurrent pregnancy loss. Okay, so the quality of the egg is affected. So if the quality of egg is affected, there's an increased risk of abortion in the first 3 months. So if the patient is like trying to conceive, do a very good shodhana and all, that also before like getting conceived, do a preconceptional care, do a proper shodhana, then advise the patient to have to conceive. And also after the menopause, especially after menopause, there's an increased risk of diabetes, hypertension, like we had discussed the endometrial carcinoma and all there's a complication. So it's a lifelong complication, it's a lifelong issue. Yeah, even after menopause, the issue won't subside. So advise the patient to follow diet and lifestyle throughout her life. Next is fibroid. So fibroid is one of the common benign tumor. It is developed from smooth muscles. It usually affects in 20 to 40% of women. Most of the time, it is like symptomless. If the patient is having heavy bleeding, or by a routine examination, or like an infertility evaluation, then only the fibroid sometimes will diagnose. Otherwise, sometimes the patient may have like some pressure-related symptoms, some heaviness in the abdomen, especially in the perimenopausal period or the premenopausal period, heaviness in the abdomen, or sometimes like a recurrent UTI. So there may be a compression to the ureter. In such cases, we will usually come to diagnose the fibroid, or it is one of the major cause for hysterectomy. Sometimes the patient may come to you telling that they were having heavy menstrual bleeding. They were advised for a hysterectomy. They are like 45 or 46 years. They want to, they want the symptom to reduce and to, like, they don't want hysterectomy. So, is there any possibility that we can subside the symptoms up to the menopausal time? So that may, if some patients may come to. So if the fibroid is large, if it is causing like compression to nearby structures, then it is always better to advise the patient to a hysterectomy. Or if it is like a heavy bleeding and all, we can manage up to an extent. So some of the risk factors for developing fibroid is early menarche, increased age as age advances, and if nulliparity, if the lady is not conceived in 35 or 36 years, then there's an increased risk of developing fibroid. So there is more exposure to estrogen. This fibroid is having a very favorable atmosphere for this hyperestrogenic state. So you can see cases with fibroid with PCOS, or PCOS subjects are having fibroid issues. So one thing we notice is that fibroid patients with PCOS subjects with fibroid, they are having the fibroid may grow very fast. They are having very large fibroid. But in endometriosis patients also you can see fibroid, but their fibroid will be size will be less than 3 centimeter only. In patients with fibroid, you can see large fibroids and high fat diet because the Kapha Prakriti subjects are having more chance of developing fibroid. There is high fat diet, vitamin D deficiency, depression, then the hypothyroidism, Agni means the metabolism is all altered. So, Kapha Prakriti subjects are having a high risk of developing this type fibroid related symptoms. So, and also if we are giving medicine to fibroid patient, advise the patient to avoid these type of cause risk factors like avoid high fatty food, avoid and check the vitamin D and correct the vitamin D deficiency. We can supplement vitamin D some C square tablet is a 6,000 unit if we are giving weekly tablet. So if we advise the patient to take one tablet in a week, so 6,000 units should be needed. Otherwise, we can give small units in alternate days and all. So fibroid usually develop from a single cell. Single, it's a monoclonal tumor. It develops from a single cell with the deposition of extracellular matrix. It start to grow into grow into a fibroid type of structure. So depending upon the area where the fibroid is, usually the fibroid develop from the uterine muscle only. It develops from the uterine muscle only. But when it encroaches into the cavity, then it is known as submucous fibroid. When it is pushed out to the of uterus, then it is known as subserous. And if it is stay inside the uterus, that is as intramural. So intramural fibroids usually this intramural. This is the this is the intramural fibroid. You can see it clearly here. This uterus is bulky also because normally uterus will be up to like the fist of a hand. Normally uterus will be like this. So this uterus is bulky because there are so many fibroids in it. So if the fibroid is if there is an intramural fibroid that is in the muscle layer, then the clinical presentation will be more pain will be the clinical presentation. So if it is encroached into the cavity, then the surface area of the endometrium is increasing, no? So the patient will complain with heavy bleeding and all. So depending upon where the fibroid is, it may cause such type of symptoms. So if it is submucous, more bleeding will be there. There will be intramural fibroid. There will be vada anubandham. So kabavada shamana we had to do. So in subserosal fibroid, there will be more heaviness related symptoms because it may grow very fast. So if the fibroids is very large, it may cause compression to a nearby structure, especially to the bladder, because uterus is anteverted. No, the upper portion of uterus is resting over the upper portion of bladder. So it is having more compression. So the patient may have the urinary related symptoms will be there. Sometimes the large fibroid may compress the ureter and all. This case regarding that. And if the fibroid is late or if the fibroid is seen near the corner of uterus where the fallopian tube is attached, so there is an increased risk of if developing an ectopic pregnancy will be there. So if the patient is planning to conceive, if the fibroid is near the corner of uterus, it is better for the patient to advise the myomectomy before planning for a pregnancy. So if the patient is having heavy bleeding and all. So first during that time we had to do a pitta shamana, like the pitta shamana line of treatment we had to give. We had to give Musalika Dadi Kashayam, Ashokavalkala Shira Kashayam, Pushyana Churna with honey, Drakshadi Kashayam. Drakshadi Kashayam Churna will be available. We can advise the patient to like to drink it muhur muhur. We like muhur muhur pana we can advise. Lodradi Kashayam, Ashokashtam Lodrasam, Chirvilu Adi. Ghritam, Mahatikta, all medicines. If the presentation is more like if the submucosal fibroid, if heavy bleeding is the presenting complaint, then we can give this Mahatikta, Triandia, the Kanjana, Regulo, such type of medicine will reduce the symptom and also the bleeding issues. And also if pain is more, if it is intramural fibroid and the patient come to you with pain, then we can give the Saptastar and Kashayam, Gandharvastadi Kashayam, Sukumaram, Kritam. Inguttriganagaidalam, Rasnashutam Payaha, or Shira Kashayam with that. So such type of, depending upon the clinical presentation, we can give the medicine accordingly. So this the Triandiatic Kashayam, which is mentioned in Vidradi, which is having very good effect in cases of this heavy bleeding, and also like in the Kanjanara Gupulu, which is having this Kaba Medohara property, which is also having very good action in this, especially if the patient is having some thyroid issue, no, then this Kanjanara Gupulu has action on both the system, this thyroid related issues, and also in the fibroid also it will is having a very good action. Then Ashogashtam Kumari Asam, Arogya Vardhani Vadi. Arogya Vardhani Vadi, we can also give in this PCOS also, but it corrects the liver function, and also it is having a very good effect in PCOS also. So management usually we can give Trayandiadi Kashayam, like Varanadi Kashayam, Sahajadi Sevyam, Chirivilvadi Kritam, Gugulu Tiktakam, like Abavitta Shamana action is very good in Gugulu Tikta if the fibroid is large and all. Uh, Arakudarishtam, Shaddaranam, and also advise the patient to avoid this excess fatty food, this chicken, such type of food. I advise the patient to avoid all those things. Next is the endometriosis. So endometriosis, it's a patient may have like severe pain and infertility related issues. So advise the patient to we had it's a third leading gynecological condition which lead to hospitalization and all, and it affects the quality of life of patient, especially the patient is having pain and all. It affects her quality. It affects the quality of her life and all, and it is the one of the major cause for developing infertility issues. So we will get infertility cases more regarding the endometriosis and PCOD and all. So the peak incidence of this endometriosis is usually said to be, theoretically it is said to be 30 to 40 years, but you can see cases from 20 onwards. So it is estimated that according to WHO, 176 million women are suffering worldwide, and there are so many risk factors for developing this endometriosis. One is it's also a family related, like genetic disorders. We can see like mother and daughter. You can see with endometriosis, or sisters or twin sisters. You can see. So age, it is theoretically said to be 30 to 40, and it is there's an increased risk in retroverted uterus, or if there is an any genital flow obstruction is there, or if more number of days of menstruation, there is higher risk, and also there is an increased risk in altered immunity. So usually like it is mentioned that theory of retrograde menstruation is a cause for developing endometriosis. Retrograde menstruation means when the new during menstrual cycle flow, the menstrual flow occurs from like the menstruation may flow out through the fallopian tube into the cavity, into the peritoneal cavity. So it may be the reason for developing endometriosis. It is a Samson's theory. So in 90% of ladies, at some point of their life, they are having this retrograde menstruation. So only subjects with altered immunity, develop this condition. So immune related issues may be also one cause for developing this endometriosis. So while treating an endometriosis patient, we had to give medicine to improve her immunity. That also we had to keep in mind. So early menarche, like late childbearing age, or late pregnancy, all may contribute to the risk. So depending upon the site of endometriosis, it can be classified into endometriosis externa and interna. Interna means inside the uterus, or in the like in the musculature, or the myometrium, that is adenomyosis, or it can be outside means it can be anywhere, even in the remote sites, or even the eyes, anywhere it can be, or in the like extra abdominal, even in the lungs and all. So there are some common areas usually are the ovary, the pouch of Douglas, and the bladder. So these are the fallopian tube. These are the common areas for developing the endometriosis. So the theory of retrograde menstruation is the retrograde menstrual flow as a result of this matrix metalloproteinase 9 is there. It disrupts the endometrial cells, which help the macrophages to phagocyte it. So if there is a defect in this matrix metalloproteinase 9 and all, the phagocytosis will not take place, or it may be cause for developing endometriosis. So altered immunity is also one major factor for developing endometriosis. So when the endometrial this tissue, that is where we all know endometrium means the presence of functional endometrium inside other than the uterine cavity. Functional means it can be stroma will be there, endometrial glands will be there. So these endometrial glands and stroma, they are very independent. They start to produce the estrogen. They have the local estrogen production, and they have more receptors than the endometrium. They have more estrogen receptors, so they will grow very fast. So they will have their own angiogenesis or blood supply. They will erode into nearby structures or erode deep into the tissues. By that, they will cause like they have the cyclic growth and shedding, which cause the local inflammation will be there. So the patient will have more prostaglandin production, and the patient will have more severe pain during menstruation. And the body try to make the inflammation into a particular area. So there will be more adhesion and all, because the body try to prevent it to further spread. So more adhesions will be produced, and as a result of this endometriosis, there will be inflammation will be seen. So the most common site of developing endometriosis is ovary. So 17 to 44% of endometriosis patients are having this ovarian endometrium. So one thing, when we are doing an ultrasonography, even if the endometriosis is seen in the ovary, so ovarian like ovarian endometrium or chocolate cyst will be developed. So it will be visible in the ultrasonography. Otherwise, if the anatomy of the uterus is altered, if the fallopian tube is like, or the ovary just like adherent to the posterior surface of the uterus, or the anatomy is distorted, then only we can understand this endometriosis in the ultrasonographically. Otherwise, small implants will be there. It won't be visible in the USG and all. So this ovarian endometrioma, when the implants start to grow in the ovary, there will be a fibrocystic cover will occur, that it will cover the chocolate cyst. The chocolate cyst will be formed by the this fibroreactive tissue, or sometimes it will develop from the ovarian cortex itself. So the fluid start to accumulate inside it, and this ovarian endometrioma will start to grow in every cycle. Every cycle it start to grow. So sometimes there will be a leaking of tarry fluid, and it may cause peritoneal irritation. The patient may have severe pain and all. Or if the endometrium or chocolate cyst is large, then it will be cause torsion to the ovary, and also there will be increased risk. It affect the normal blood supply to the ovarian also. So the clinical presentation will be definitely, it will be severe pain and abnormal menstruation. Abnormal menstruation means the patient will have severe bleeding or brownish spotting throughout, sometimes throughout the cycle, or like 2 to 3 days prior to the menstruation, or even after menstruation they will have brownish spotting. So that may be the abnormal menstruation, the clinical presentation you will get. And of course, infertility will be one of the clinical presentations. So chronic pelvic pain, the patient have like pain throughout the cycle because of the local inflammation, because of the adhesion will be there, there will be throughout the pain. So, and this pain is there because of the most prostaglandins. There will be more thromboxane will be produced as a result of local irritation, and all the patient will be have pain. So, in such type of cases, we can give like more of like pitta shamana, shodhara type of medicines we can give. Like if we are giving like nurgundyadi, mahatiktakam, guduchiyadi type of medicines, or even gopi chandranadi, gupgulu panchavalam, such type of medicine will reduce the inflammation. Punarnavadi kashayam, or all are having effect or to reduce the chronic pelvic pain. Next is the patients may complain to about you about dyspareunia. Dyspareunia is deep dyspareunia, they will tell, because of if the implant is seen in the uterosacral ligament, or in the pouch of Douglas, or in the rectovaginal pouch, then the presenting complaint will be dyspareunia. So this pain will be more like a few days prior to the menstruation. So if a patient come to you, tell you about dyspareunia, there are mainly so many causes. Like if it a pelvic this PID or this endometriosis may have deep dyspareunia. Superficial dyspareunia, if they are having like a menopausal lady, perimenopausal lady, they are having this less lubrication or vaginal atrophy, or even ladies with less estrogen production, or dryness of vagina, or inadequate lubrication, vaginismus, all are having superficial dyspareunia. So we had to differentiate that. So menstrual irregularity, usually they will present with heavy menstrual bleeding or like spotting. Such type of presentation will be there. So in between cycle, we can give like Trayandyadi or even Avivati Churna will also reduce this pitta type of pitta shamana line of management. We can give good result. We can get good result. Then adenomyosis also, sometimes when you are doing a USG, you can see bulky uterus. The uterus will be bulky. It's one lab, it one ultrasonography finding. So bulky uterus you will get in adenomyosis, and also in fibroid uterus you can see this bulky uterus. So in such case, in this adenomyosis also, that is endometriosis, which is seen in the uterine musculature. That is adenomyosis. In such cases also, we will get severe pain, severe pain and heavy bleeding. These are the two main presentation we will get in adenomyosis. And also the pain usually subsides slowly after menstruation. That is one typical sign of this adenomyosis. Next is infertility issue, because as related to this pelvic inflammation, adhesion, the pelvic normal pelvic anatomy is distorted. So the normal ovulation, even in endometriosis patient, even with their if they don't have any chocolate cyst or ovarian endometrioma, the normal ovarian function is always altered when when endometriosis is there. So the normal ovarian or ovulation will be absent, or if ovulation is happening, the fallopian tube will not pick up the ovum. So such type of reasons may be a cause for infertility. And also if for sometimes fertilization occurs, the endometriosis affect the implantation molecule, so improper implantation will not be take place. So there are so many factors for developing infertility in endometriosis patient. So when we are doing our management, usually the Vada Pradhana treatment we had to adopt. So depending upon the symptom, like if there is more bleeding, if there is more adhesion, like that we can advise like more if the more bleeding related issues is there, we can give like Vada Pitta Shamana line of treatment. If adhesion related issues are more, then we can give like Vada Kaba Shamana treatment as will be more. So that's depending upon the symptom, we can advise like dysmenorrhea is there, dyspareunia is there, this according to the symptoms, we can classify it under Vadiki, Udavartini, Paripluda, Rektapitta, and this Vadika Pradara. Like that, we can classify. And also, we can adopt like Vada shown the line of treatment in this condition. So first thing is Vada Shamana is main line of treatment. And internally we can give this common medicines like Sugumaram. Sugumaram Kashayam is better. Sugumara Kridam is not advisable, especially for Snehapana and all. Sugumaram Kridam is not advisable for endometriosis, even if they are suffering from infertility. It is having some action to improve the, so it will increase the endometriotic cyst. So better avoid Sugumara Kridam for Snehapanam in endometriosis patient. We can give Chirivilvadi Kashayam, Gandharvastadi Kashayam, Mahatiktakam Kashayam with Kanda Siburam is having very good effect. Then Hinguachadi Churnam, Gugulu Panchapalam Churnam, Gopi Chandanadi, Guluchadi. We can Kashayam, we can give it as a toyam also. Virejana we can give, Avipati Churna we can give Virejana in Mrudu Shodhan also we can give, or also in Shavana Mata like 2 gram with honey in alternate days we can give. Arishtam also, like the another Arishtam Punarnavasam, all are having effect to reduce the inflammation and pain. So if we are opting for Grida, we can give this Dadimadikatam, Kalyanagam, Tiktagam, even we can give Mahanayarana Thailam or Madhu Ishtya Thailam in order to reduce the pain. And we can also give this Vasti with this Mahadaranam, Madhu Ishtya Thailam. It is also having very good effect in reducing the pain and all. Next is premenstrual syndrome. Premenstrual syndrome means some of the mood swings or some symptoms which occurs prior to menstruation, especially 5 to 10 days prior to menstruation, as a result of this higher level of vasopressin level and all. So some patients may come to with premenstrual symptoms. Some may have more Vadika type of lakshana like anxiety, back pain, fatigue, like pain, shirashulam, or some patient will come to you with migraine, especially like 2 to 3 days prior to menstruation. Such a type of symptom like Vadika type of lakshanas we will get. So our line of management should be Vada Shamana. We can give Danudaram Kashayam, Drakshadi Kashayam, Maharasnadi, Shadavari, Adika, Kulam we can give, Kalyana Gratham we can give. So if some patient they are having like very much of pitia type of affliction, they are having like hot flashes, they have mood swings, irritability. So in anger, such type of patient we can give like Pitta Shamana line of madam, like we can give Tiktagam, Mahatiktam, Kasham, Eshti Madhuchurnam, Shari Badhyasvam. We can give Talam with Kachoradi Churnam and Shira Bela Talam. We can it will reduce the stress related issues and all. If the patient is having like more of like depression, tearfulness, bloating, some patient will gain 1 to 2 kilos prior to menstruation. So in such type of this Kaba Lakshana, we can give Kashan type of medicines we can give. So next is the vaginal discharges. So normally vaginal discharges will be there, no? So usually 1 to 4 ml will be, if per day will be there will be secretion. So the secretion is from the Bartholin's gland or thin, and it is odorless only. That is a specific pattern we can see, and there will not be any itching. There will not be any burning sensation. So in physiologically there will be excess secretion we can see in pregnancy, and during sexual contact also there will be physiological excess secretion will be seen. Otherwise, there will be only mild secretion will be seen. So the abnormal vaginal discharge, as if it is seen, we had to ask about the color, the smell, and the itching is there, and all or the pain or is there any burning sensation will be there. Such things we had to ask, and we can adopt chiklisas like Univyapit, like Paripruda, Paitigi, type of Slaishmigi type of chiklisa we can adopt, or we can adopt chiklisa like Jwaram, Krimi chiklisa, Pandu chiklisa. So if there is anemia, show the chiklisa we can give. Prameha Aushadhi, if there is like more of candidal type of infection, we can also give Prameha Aushadhis also. So if there is more itching and all, we can suspect if there is Kaba and Bandha is there. So examine if there is a discharge is there, try to examine the patient and like look for any tenderness in the quadrants of the abdomen, especially in the iliac fossa and all. And also look for the vulvovaginal area if there is an inflammation or like signs of any like itching or like scratching. Sometimes the patient will scratch more and we can see the scratching, or like we can see the wound there. So look for any vulvovaginal inflammation is there, or like in a perimenopausal lady, look for any atrophic changes or drynesses we can see sometimes. And also sometimes while examining, we will just inspecting itself, we can see thick discharges in the vaginal opening itself we can see. So that also we can, in the first inspection itself we can see such type of discharges. So then also, if we are doing a bimanual examination, we can see, we can, if we are doing a bimanual examination, or even in a cervix, or if you are doing a bimanual examination, that is with two hands. One hands will, these two fingers will move the cervix. If you are moving the cervix, there will be severe pain. So the cervical motion, the tenderness is positive, then we can suspect the PID related symptoms, or the patient may have like pain, fever type of presentation will be there. So anemia is also one thing we had to exclude when we are treating a